Welcome to Genitourinary Pathology Society Virtual Education Series. My name is Dr. Rajal Shah. I am Professor of Pathology at UT Southwestern Medical Center in Dallas, Texas, and also President-elect for Society. Today, in today's webinar, we feature 3 GU experts who will be presenting their interesting cases using PathPresenter, a virtual microscope-based educational platform. Each presentation will be about 17 to 18 minutes, followed by 4 to 5 minutes of question and answer sessions. So please drop your questions in Q&A box. I will give a very brief introduction about this GUPS-PathPresenter initiative. So recently, GUPS has partnered with PathPresenter to develop a high-yield urologic pathology digital slide collection module. This is an important initiative for the society, and we hope that all trainees and members will take advantage of. So we had 4 objectives in building this collaboration: to develop a global educational program that can simulate teaching over a multi-headed scope. We wanted to develop a library of must-know urologic diseases, prepare trainees for boards, and provide members update on new scientific developments occurring in these high-yield topics. So this program was launched in January of 2021. It has now about 70 fully annotated high-quality digital cases ready for your learning. New cases are periodically added. The module can be accessed through the GUPS or PathPresenter website. You require registration and login, but most importantly, this resource is free for all. We also feature 1 case every month through our social media Twitter platform, and also send the link to all members via email communication. So once you are on the PathPresenter homepage, look for High-Yield Cases app. And high-yield urology cases are in the folder under the GUPS heading. We have divided the content into 5 major organ categories for your easy and systematic learning. The platform also has several important learning tools to simulate interactive teaching that you can receive over a multi-headed microscope with an expert. One of such features is annotation features. So in every case, important features are annotated using this underlined text. So when you click this text, it will take you directly linked a feature on a class slide. For example, in this case of seminoma, I'm showing this in situ trophoblastic giant cells annotated feature. Another interesting tool is a differential diagnosis section, where you can do side-by-side comparison of the entities under differential. So with this brief introduction, I would like to welcome our first speaker for today, Dr. Preeti Lal. Preeti is an associate professor of pathology and director of genitourinary pathology service at University of Pennsylvania. She received her APCP residency training at UMDNG New Jersey Medical School, followed by a fellowship at Memorial Sloan Kettering Cancer Center. Preeti's research interests include bladder and prostate cancer. She serves as a pathology PI for several NIH-funded grants. Preeti will be talking about an interesting spectrum of urothelial lesions with inverted or endophytic growth. So without any further ado, I welcome Preeti. Preeti, please share your screen.
Rajal, you have to stop sharing your screen. It says I cannot tell you are sharing.
Okay. I stop sharing.
All right, perfect. Hello, everybody. Can you see my screen?
Yes.
Welcome to this session, and thank you, Rajal, for the introduction. Thank you, GUPS, for providing this platform, and to Dr. Fine and Dr. Shah to host this event. As Rajal introduced, my topic today is inverted urothelial lesions in the bladder. So this talk is going to be about 15 to 18 minutes long. It's a big topic to tackle. So I'm just going to give you a brief outline of how I have put this talk together. We'll lay some basic definitions down by going over the WHO classification of non-invasive papillary urothelial neoplasia. I'll spend a substantial amount of time discussing the inverted urothelial papilloma so as to be able to draw the differential diagnoses that come to play when you are making a diagnosis of benign entity. And then go over a little bit in more detail into the various benign entities that play into these differential diagnoses, some malignant entities that one should always keep in mind, and some indolent appearing, more aggressive behaving entities that come into play. So the WHO recognizes 4 distinct papillary lesions: papilloma, which, as the name suggests, is a benign proliferation; pun lump, or the papillary urothelial neoplasia of low malignant potential. These 2 entities on cystoscopy appear as simple translucent papillae. And while papillomas are lined by normal-looking urothelium, papillary urothelial neoplasia of low malignant potential, which I'm going to use the short form pun lump, is lined by, these simple papillae are lined by hyperplastic-looking urothelium. And we're going to repeat some of this information over the talk just to draw the parallels. Now, the low-grade and high-grade papillary urothelial urothelial carcinomas have much more complex proliferation, and on cystoscopy, these appear to be more complex as well. Here is a more diagrammatic representation. What does normal urothelium look like? It usually has a basal layer, intermediate layer, and an overlying umbrella cell layer. In an hyperplastic urothelium, the number of layers increases. There is no defined number of layers that one can draw upon, but it is a relative number of increased number of cells. Now, normal urothelium itself has a range of appearance. Now, here I show you 2 side-by-side sections from a papilloma, and you can see while on the top, the number of intermediate cell layer is much less, like 1 or 2 layers, some tangentially cut layer. The one at the bottom has multiple layers in the intermediate. So there is a range to that as well. Similarly, in pun lump, there is a range of appearance that you will see, but the main idea to remember is that the nuclear atypia is minimum to almost normal looking nuclei. These nuclei still tend to be oriented perpendicular to the basement membrane. You may or may not see the umbrella cell layer. Now, drawing the analogy of these exophytic proliferations to normal and inverted lesions that we recognize helps us develop our concepts to build upon as we go from textbook examples to more into our clinical practice, where overlapping appearances are more common. So WHO exophytic lesions, papilloma, pun lump, low-grade non-invasive papillary urothelial carcinoma, and non-invasive high-grade papillary urothelial carcinomas. In flat lesions, you have the normal urothelium, urothelial hyperplasia, urothelial dysplasia, which is a very tough diagnosis to make, and urothelial carcinoma in situ. So a lining which looks normal in an endophytic growth will be seen in an inverted papilloma, hyperplastic lining will be seen in an inverted pond-lump lesion. And similarly, low and high-grade inverted lesions will have these kinds of appearance. So on cystoscopy, urothelial papilloma has fine finger-like projections. This is shown up on the left side here, corresponding H&E image. Because inverted papillomas, majority of the growth happens below the surface is smooth. Often these are pedunculated lesions. Sometimes they can be sessile. Majority of these will be single lesion, solitary lesions, but multifocal lesions have been described. So I have minimized the number of slides with text, but this is a mandatory, just going over the clinical presentation and epidemiology of inverted urothelial papilloma. Majority of these patients present with gross hematuria or microscopic hematuria. Some may have lower urinary tract symptoms like irritative symptoms, dysuria, and in the upper tract, if there is an obstruction of the outflow, they may present with the flank pain or low back pain. Epidemiology, as with all other urothelial lesions, they are more frequent in men compared to women. And if you look at the literature, there's a whole list of different ratios, but on an average, it can be said that 7:1 is a good ratio. These are seen in older age, in a whole range of age group, from young patients to older patients, with a mean age of 60 years. All right, so here are three images of an inverted urothelial papilloma. I want you to look at the surface of the proliferation. On the top, you see a very attenuated urothelial lining. And here on the left lower image, you see a little bit more kind of a reactive surface. There are some umbrella cells easily visible. And on the right side, you see a very denuded papilloma. So the surface lining can be variable in these proliferation. One thing that is common, as you can see, the ribbon-like or trabecular growth pattern that you can recognize in all three lesions. And at low power, a classic inverted papilloma will have a nice basal layer that you can easily recognize. And sometimes it's more prominent and other times it's less prominent. The stroma is also variable in amount. They can be edematous, very well separated out, edematous stroma that separates out the cords, versus those that are more compact. So here is a closer look of the urothelial lining, and you can almost see how there is a basal layer, an intermediate layer of nuclei that are oval in shape, perpendicular to the basement membrane, and then perhaps the lighter areas here are the surface layer of what would have been a normal urothelium with inverted growth. The normal thickness of these is described as 5 to 10 cell layer thick. And as I said, they preserve their polarity. If mitoses are seen, they are usually in the basal layer because these lesions do proliferate. Streaming of the centrally located cells is often seen, and you can even, in some examples, you can even see it at very low power. Now, this is a demonstration of how you can drive your own slides in PathPresenter, and this is one of my cases in which I scanned in PathPresenter. Now, this is an entirely, excised lesion, and the base here was sitting on this basal, a resection of the base of this lesion. So you can see that while it is not continuous, there is a distinct line which separates the outline of this lesion, and there is no proliferation seen in the tissue that was that this lesion was sitting on. So a very well circumscribed proliferation. And as you go to scroll to higher power, you can see not only are the trabeculae or branching and interconnected, but sometimes they have inverted urothelial papillomas reveal these cystic regions. And you can see how the surface lining is pretty attenuated, and the stroma itself is variable in this case. So not all cases are very classic. Sometimes they can be very compact proliferation, in which case one has to remember that tangential cuts through these three-dimensional structures can look like they are broad. So one has to take into account the low power as well as the high power characteristics of these lesions. Some unusual findings could be squamous differentiation within inverted papillomas, degenerative atypia, cyst formation with, inspissated kind of pink material. And one has to remember that the keratinization has to be squamous regions should be non-keratinizing. So compact growth, tangential cuts can look a little bit large. And this is important to remember as we go into the differential diagnosis of inverted papillomas. So this is another example of inverted papilloma where you can see how there are little nubbins of growth, and it is thought that the inverted papillomas actually arise from the basal layer, and you can see how these buds of proliferation are giving rise to the inverted growth. Okay, so now what about exophytic component? Depending on the literature that you follow, the exophytic component may or may not be acceptable. According to the AFIP fascicle, there should not be any exophytic component to true inverted papilloma, whereas WHO says that there may be some small component. One thing that one has to absolutely remember is that if there is a small component of exophytic papillary growth, this has to be lined by normal looking urothelium. There shouldn't be any fusion, and there should not be any history of previous urothelial carcinoma. So be very careful making this diagnosis in a patient who, in fact, I would say try not to make this diagnosis in a patient with a history of urothelial carcinoma. So I would suggest follow very strict criteria as you make the diagnosis of this benign, mostly benign entity. Make sure that the cords and trabeculae are composed of bland cytology. Look at the overlying urothelium. When present, it should look as normal as possible. There should be a sharp delineation between the underlying stroma and the growth, inverted growth pattern. There should, some of the cautionary notes are previous history of urothelial carcinoma, a presence of exophytic component, any degree of cytologic atypia, large confluent nests in the stroma, and irregular intersection between the base of the lesion and the underlying stroma. So as far as molecular studies are concerned, there have been numerous molecular studies conducted over the years, and it is becoming clear that the exophytic or usual papillary urothelial papilloma is a different entity compared to the inverted urothelial papilloma. There are some similarities in the terms of the fact that both are driven by the RAS-ERK pathway. However, urothelial papilloma predominantly have the KRAS mutations, whereas the inverted urothelial papilloma predominantly show the HRAS mutations. There is a low incidence of chromosome 9 LOH in inverted urothelial papilloma. FGFR mutations can be seen in urothelial papilloma, but are not seen in inverted urothelial papilloma. So there are some benign entities that one needs to keep in mind as we are working through the differential of inverted urothelial papilloma. These are benign entities that we see very commonly in our practice, that is cystitis cystica, von Brunn's nests, and cystitis cystica glandularis. If one keeps the definition of classic urothelial papilloma in mind, which is shown here for comparison, one will see the cords and the arborizing, cords of inverted urothelial papilloma. Whereas in von Brunn's nests and cystitis cystica, etc., you will see more of a lobulated growth with separated out nests of cells. So while they are normal looking, the growth pattern is very different compared to the inverted urothelial papilloma. Then there is the pun lump, where it is, lined by hyperplastic urothelial epithelium. And here is a side-by-side comparison of inverted urothelial papilloma, what is a published case of inverted growth in pun lump and inverted growth in low-grade papillary urothelial carcinoma. What you can see here is very even population in an inverted pun lump, and some nuclear atypia started to show in the inverted low-grade papillary urothelial carcinoma. So for the sake of time, I will skip this slide, which is essentially the same point. And here is an example of inverted growth of a low-grade papillary urothelial carcinoma. In majority of the cases, you will see an exophytic component when there is inverted growth. So the differential diagnosis is most of the time easy. Here is an example in GUPS-PathPresenter, where you can see that low-grade papillary urothelial carcinoma, which here is obvious papillary growth formation, can have inverted growth pattern and also show more like cystitis cystica-like areas in some cases, but nuclear atypia gives the lesion away. This is a quick show, the slide that I wanted to show, where there is this lesion with endophytic growth pattern, has areas that look like inverted urothelial papilloma and those that look like inverted pun lump. But what gives away is the true papillary growth here on the right side, and this was actually a low-grade papillary urothelial carcinoma. Then there are some very aggressive lesions, malignant lesions that can come into play, large nested variant and small nested variant that can that have a very indolent looking cytology. But in majority of the cases, you will have an exophytic component. Small nested variant can have cystic regions, and one has to remember benign differential diagnosis like cystitis cystica, nephrogenic adenoma with a cyst formation, and cord formation can be seen in small nested variant as well. But of course, the nuclear atypia will help you make the distinction. So in summary, inverted urothelial papilloma can have various differential diagnoses, and each of the WHO non-invasive papillary urothelial proliferations can have their corresponding inverted components. Beware of indolent looking aggressive lesions that can mimic inverted growth pattern. And with that, I think I'm running out of time. So I leave you with the summary where benign entities, when recognized correctly, will of course behave in their expected pattern, but beware of, so to say, a wolf in lamb's coat, where indolent looking histology is actually associated with aggressive behavior. And then there is everything in between. Tommy or pet dog can sometimes be more aggressive, and accumulation of mutation can have been associated with aggressive behavior in a subset of indolent entities. So with that, I end my talk, and these are all my references that I have used. And I thank you for your time and attention.
Thank you very much, Preeti, for that excellent presentation. You really made a complex subject look quite easy. So I don't believe that we have any questions from the audience, but one question that maybe I would quickly ask is that, have you used TERT mutation? There is some literature whether TERT mutation can be helpful in distinction of benign from malignant processes.
Yes, there's definitely literature, but we haven't really used it. This actually, the last case that I have flashed up here was a very difficult case where you could see the arborizing proliferation going from surface into the lamina propria. There was not much in terms of nuclear atypia. And this was a very younger patient where the differential diagnosis was nested variant versus, diffuse von Brun's nest. And in such cases, TERT mutation, if you have it, would be helpful.
Okay, very good. So thank you again, Preeti.
Thank you.
I will share the screen now. So our next speaker today is Dr. Sarah Walker. Sarah is an associate professor of pathology and urology and director of genitourinary pathology service at the University of North Carolina, Chapel Hill. At the same institution, she also received her APCP and cytopathology fellowship training, followed by urologic pathology fellowship at Johns Hopkins Medical Center. Sarah's research interests include molecular characterization of histologic subtypes of urothelial carcinoma and also development of new practice guidelines. So Sarah will be talking today on a spectrum of Sertoli cell tumors of testes. So I would like to welcome Sarah. Sarah, please share your screen.
Thank you, Dr. Shah. We'll release the screen. Okay. Hold on. How does that look to everyone?
It looks great.
Looks good, yeah.
Great. Okay, so today I was asked to discuss a testis topic, and I chose the spectrum of Sertoli cell tumors. And I think this is a nice framework to discuss the new WHO classification, which just came out, where there's some kind of recategorization of some of these tumors. And so I'll start with essentially just an overview. Obviously, we're not going to discuss the entire testis classification, but from the new classification, germ cell tumors, which take up the vast majority of testicular malignancies with greater than 90% of tumors. So those are divided into germ cell tumors derived from germ cell neoplasia in situ, and those germ cell tumors that are unrelated to germ cell neoplasia in situ. And we're not going to talk about those today. Those are kind of the ones that get the most attention. So we're going to focus on the much less common category of sex cord stromal tumors, which are less than 5% of testicular tumors. And this group includes Leydig cell tumors, which are the most common by far, with over 90% of sex cord stromal tumors representing Leydig cells. Sertoli cell tumors are the second most common, but overall very rare, and occupy, of all testicular tumors, less than 1%. So we're discussing these today because they're interesting and they have a real range of morphologic patterns. But again, these are fairly rare. Within the category of Sertoli cell tumors, we have a couple things to point out from the new classification. So large cell calcifying Sertoli cell tumors may occur both sporadically and associated with Carney syndrome. So that's why I have this third category here, which is the third category, actually the fourth category in the new classification of genetic tumor syndromes of the urinary and male genital tract. So this large cell calcifying Sertoli cell tumor is now discussed both here with the sex cord stromal tumors and also here in the genetic tumor syndromes, and that's because of its association with Carney syndrome. So going back to the sex cord stromal tumors and classification, you'll see sertoliform cystadenoma is now discussed as part of the Sertoli cell tumor family, and that has been moved from the adnexal tumors, and we'll talk about how that came to be. So the other sex cord stromal tumors that are included but less common: granulosa cell tumors, fibromethicoma, and then mixed and others. So one of the recategorizations that happened here is that rather than mixed or undifferentiated sex cord stromal tumors, we now have mixed, which means that there is a component of either Sertoli cells or Leydig cells or granulosa cells that is readily identifiable. So you can tell, there is in fact a morphologic recognizable sex cord stromal component. The sex cord stromal tumors not otherwise specified are these tumors that we can get into the category of sex cord stromal, but lack any recognizable features of one of the specific cell types. So these were sort of formally known as undifferentiated tumors. Others that are exceedingly rare and sort of beginning to be increasingly recognized and studied are myoid gonadal stromal tumor and signet ring stromal tumor. So just briefly to touch on this genetic tumor syndromes category, I pulled out a few things which include testicular or adnexal tumors relevant to kind of understanding the new classification. So again, we've already discussed large cell calcifying Sertoli cell tumors. Intratubular large cell hyalinizing Sertoli cell tumor is associated with Peutz-Jeghers syndrome, and I won't talk about it at length because I don't have any pictures of it. So would love to get one of those scanned to PathPresenter in the future if you have one. But this is one of the syndromic associated testicular tumors. And then an adnexal tumor that we're a little more familiar with, papillary cystadenoma of the epididymis, which is associated with von Hippel-Lindau syndrome. So I won't discuss that today, but just wanted to include it in the discussion as the new classification includes these genetic tumor syndromes. So moving on to our PathPresenter slides, the first one I'm going to start with is just our, standard classic Sertoli cell tumor. And this is one of the high yield cases that is included in the GUPS high yield section. So Sertoli cell tumors, they're typically very well circumscribed, which we can see here. It's got a very distinct border here, kind of pushing the adjacent testicular parenchyma out of the way. And even at lower power, we're beginning to see what looks like some tubular growth here. So Sertoli cell tumors, generally, at least focally, you will be able to identify these nice tubules. Sometimes they sort of collapse on themselves. They look a little bit more solid, like a small nest. But at some point in your scanning through these tumors, you will be able to find some degree of tubular growth pattern, because that is just what these Sertoli cell tumors are meant to do. They're derived from Sertoli cells, which line the seminiferous tubules. So they're trying to recapitulate that. So within, sort of between our nests and cords of Sertoli cells, there's going to be varying amounts of these fibrous bands. And you can have tumors that are made, sort of excessive fibrous tissue and bands. And when it's greater than 50% of the tumor, those are referred to as sclerosing type Sertoli cell tumors. And interestingly, those seem to have a better prognosis overall. Those are pretty rare, but usually the combination of, some amount of tubular growth pattern and these fibrous bands is going to be your hint that these are of Sertoli cell origin. So other things that you can point out about these Sertoli cell tumors, very bland cytology. These are very monotonous, small nuclei, round, single nucleolus. Effectively, each cell looks like its neighbor. Very little pleomorphism here. You will notice in areas some of these cells have far less cytoplasm than others. So we're in an area where we can kind of compare to the left side of the screen. We've got these very small nuclei with hardly any cytoplasm around them, whereas over here we're beginning to see more abundant cytoplasm. Some of it is sort of vacuolated. Some of it has what looks like individual large vacuoles in it, so almost imparting a sort of signet ring look to it. So that comes into play when considering the differential diagnosis of these tumors, which, depending on what area you're seeing, again, this sort of signet ring-like appearance could potentially confuse you for a adenomatoid tumor. Again, those are typically going to be paratesticular, adnexal, but can sort of push in and involve the testicular parenchyma. So there is a differential diagnosis for these tumors, and we'll sort of go over that towards the end. But just to sort of frame the conversation to begin with, discussing Sertoli cell tumors, these very nice, well-circumscribed, small tumors with some component of tubular growth pattern. So back to the slides. The next entity that we'll discuss is the large cell calcifying Sertoli cell tumor. So this is the sort of unique variant that occurs. About 60% of them are sporadic, so just occurring in no setting of known syndromic manifestations. So 40% of these are associated with Carney syndrome, which has a real spectrum of other lesions and presentations, including skin, lentiginous, atrial myxomas, really just a full spectrum. So it's fairly rare that the first presentation would be, a patient who comes with a testicular mass and it turns out to be a large cell calcifying Sertoli cell tumor, and that's the clue to Carney's. But it could happen, so it's good to be aware of it. But grossly, at low power, we see, unlike the usual type of Sertoli cell tumor, this has got sort of a more infiltrative or multilobular pattern of growth. You can't just draw one nice circle around it. And here's an example of how in PathPresenter you can use these annotations that for us, as we're trying to discuss these cases, will sort of zoom us right into these areas that we want to discuss. So multinodular, poorly circumscribed growth pattern for these large cell Sertoli cell tumors. And then clearly, if we're talking about something that has calcifying in the name of it, we're going to be looking for these calcifications. And I think one thing that's worth pointing out here, even though there's not a ton of large calcifications in here, look at how many of these tissue artifacts we're seeing, basically because histology went to cut into these tumors and just chunked out all these calcifications and dragged it across the slide. So that's sort of a soft finding for the fact that there's calcifications in here. So here, just indicating some of those cutting artifacts. So these large cell calcifying Sertoli cell tumors frequently have some component of intratubular growth pattern here. It's not an exclusive intratubular growth pattern. That would be what you would expect in the intratubular hyalinizing Sertoli cell tumors associated with Pete's Jaeger. In terms of growth pattern, you can see sort of a combination of kind of nests and cords. Here's another example where they're making sort of more cords, but focally somewhere you're going to be able to find, again, those more tubular growth patterns that you expect in a Sertoli cell tumor. A unique feature of these large cell calcifying Sertoli cell tumors is this neutrophilic infiltrate. And in this case, it's really, really prominent. So quite extensive and unusual finding in other Sertoli cell tumors. And then, as you would expect, cytologically, again, it's in the name. These are large cells, abundant eosinophilic cytoplasm. You can see, though, sort of the nuclear size and shape, again, very monotonous. The neighbors all pretty much look the same. So a rather bland tumor all in all. One thing that's important to point out is sort of a potential pitfall with these large cell calcifying Sertoli cell tumors is how pink they are, eosinophilic. So certainly you could see the confusion could come up with a Leydig cell tumor very easily, given these very abundant eosinophilic cytoplasm in these tumors. So we'll move on to the final case that I wanted to discuss, and then we'll go over some of the sort of workup and differential. So Sertoliform cystadenoma of the rete testis. These tumors are they are centered in the rete testis. So we have here a sort of circumscribed mass here that's really just adjacent to the testicular parenchyma. It's not involving the testicular parenchyma. And then at closer magnification, you can begin to see sort of the remnants of your really sort of unaffected rete testis back here with these slit-like areas. But because these tumors kind of obstruct and grow within the rete testis, you can begin to see this kind of cystic dilation of the rete testis. Then here's a really nice example of how this tumor is really kind of growing into and expanding the rete testis channels here. So as with all Sertoli cell tumors, these Sertoliform cystadenomas do show this tubular growth pattern that you expect to see. The cells may be embedded. I find in the few of these I have seen, that this sort of myxoid stroma is a very helpful feature for the sertoliform cystadenoma. But in other areas, variably, it's more fibrotic. So can certainly be kind of an admixture of background stroma. And then again, these are benign Sertoli cell tumors as of the new WHO classification. So we expect to see monotonous round nuclei with very small, fairly conspicuous nucleoli. One thing just to point out here, because this had a nice example for all of these tumors, is to be sure that you look at the surrounding seminiferous tubules. And here we see that there's nice, active spermatogenesis. There's no evidence of germ cell neoplasia in situ. So that's to help basically get us to our, exclusion of could this potentially be a germ cell tumor of some type. So moving on to kind of our summary and what we need to do to work these up. Differential diagnosis, depending on, we've seen these have a whole range of morphologies. So depending on what you are seeing, you could consider a germ cell tumor, adenomatoid tumor, neuroendocrine tumor with that cord-like growth, Leydig cell tumors when there's those abundant eosinophilic cytoplasmic areas, and then Sertoli cell nodules, which have more kind of immature Sertoli cells and look a little different. But to get into the right category of sex cord stromal tumors, most of them will express SF1, steroid factor 1, and Sertoli cell tumors in particular consistently express keratins and nuclear beta-catenin, and they have variable amounts of expression of vimentin, inhibin, and calretinin. So if we're trying to exclude a germ cell marker, Sertoli cell, or a germ cell tumor, Sertoli cell tumors will be negative for SAL4, OCT4, and the other specific markers. Also, if you have a real problem, isochromosome 12 would be negative in Sertoli cell tumors. They're also negative for mesothelial markers, EMA, CK7, WIT1 that you would expect, say, in an adenomatoid tumor. And then just a reminder to always evaluate the adjacent tubules for germ cell neoplasia in situ. So prognostically, the vast majority of Sertoli cell tumors are benign, but they do have the capacity to metastasize. And the proposed criteria that are suggestive of malignancy include large size, greater than 5 centimeters, an infiltrative, invasive pattern of growth, vascular invasion, high-grade cytologic atypia with nuclear pleomorphism, high mitotic rate, and necrosis. So in terms of, what do you do with these criteria if they're absent? I think that it is standard to say Sertoli cell tumor, see note, no evidence of the, sort of adverse features of, 1 through 6 are seen. If they are present, obviously you want to comment on them, as there is, some evidence that 2 or more of these adverse features is potentially a strong enough indicator of potential metastatic capacity that some groups would advocate doing an upfront retroperitoneal lymph node dissection, but that's somewhat contingent. So that's all I have, and I'm happy to answer any questions that you guys may have.
Thank you very much, Sarah, for a wonderful presentation on this rare subject. So we have one question from the audience. Since large cell calcifying Sertoli looks different, do you know why they are still lumped under the Sertoli umbrella? I suppose because of tubular formation. And I think please go ahead and. It's
Sure.
actually
So,
Sean Williamson is raising this question.
Yes, so thank you, Dr. Williamson. So, well, they do look different, but I think the fact that they occur sporadically, they're not just, distinctly occurring in a syndromic setting only, and they have the same, immunoprofile. They do have a unique genetic findings. So the large cell calcifying Sertoli cell tumors are associated with the PRK I always get this wrong. PRK. Find it. The PRK. Oh, I've lost it already. PRKRA1. I'm on this paper and I can't remember the actual mutation, but in sporadic tubers, they're frequently identified this, sporadic acquired mutation versus a germline mutation in the carne-associated tumors. So I think for now, because they are occurring in the sporadic setting, that they do appear to have sort of a histologic subtype of Sertoli cell tumors.
Thank you very much, Sarah. Other question is from Masa Biltrup, whether Sertoli cells are WT1 positive.
I don't know if there are instances, but generally speaking, they are negative.
All right, I think for the benefit of time, we'll move on. Again, thank you very much, Sarah, for this wonderful presentation. So I will share my screen. Our final speaker for today is Dr. Lara Herrick. Lara is an associate professor of pathology and director of genitourinary pathology service at Emory University School of Medicine. She received APCP training also from the same institution, followed by oncologic surgical pathology and urologic pathology fellowships at Memorial Sloan Kettering Cancer Center. Lara's research interests include metastatic prostate cancer, bladder carcinoma with variant histology, and through her role as a committee member of GAP Cancer Committee, she also is involved in developing geosynoptic reporting template. I think one thing you guys perhaps have noticed that there is a clearly woman power. I think all of three have been director of the genitourinary pathology service. Great. So I think Lara will be talking about a spectrum of cystic lesions of the kidney. So Lara, welcome, and please share your screen.
Thank you so much, Rajal, for this kind introduction. Can you all see my screen?
Yes.
Okay, great. So I'm very happy. Thank you all for joining us. I'm very happy to be here today and discuss cystic lesions of the kidney, focusing on neoplasms. I have no disclosures related to this topic. So I will start with a case presentation. Oops, hold on. I'm gonna try to remove the. I will start with a case presentation of a 43-year-old male who presented to his primary care physician with back pain, and they performed an MRI to investigate the back pain. And he was found to have incidental lesions on his kidneys, both the left and the right. The left kidney had a 1.1 centimeter exophytic cystic Bosniak 3 lesion, and the right kidney had a 1.5 centimeter Bosniak 1 cyst. They referred him to urology, and urology decided to watch him. 2 years later, he, on CT scan, the lesion in the left kidney, which is the 1.1 centimeter Bosniak 3 lesion, grew to 2.3 centimeter, and so there was interval growth, and he was referred again for surgery. And that's when we got the partial nephrectomy on this patient. So what exactly is the Bosniak classification? It's a radiologic classification for cystic lesions in the kidney. And you can perform it on both MRI and CT scan. And it takes into account the number of septa that the cystic lesion has, the thickness of these septa, as well as the presence of nodules and the characteristics of the nodules within the cystic lesion. So the Bosniak classification goes from Bosniak 1 to Bosniak 4, where Bosniak 1 and 2 are benign lesions, no need for follow-up. Bosniak 4 are likely malignant, and so therefore urology consultation and potentially definitive therapy are recommended. And then of course we have the gray zone, Bosniak 2F and Bosniak 3. Bosniak 2F are when you have septa that are 3 millimeters thick or enhancing, and so therefore most likely are benign, but follow-up is recommended. And then the Bosniak 3, those are the intermediate probability of being malignant and usually have a septal thickness of 4 millimeters or nodules that are present within them. And so, of course, our patient was a Bosniak 3 lesion. It was 1.1. Within 2 years, it grew to 2.3. So they were worried about it and they excised it. And that's when we got it. On in pathology. The specimen showed a well-defined lesion that seemed to abut the renal parenchyma in some areas, but in other areas seemed to intermingle with the renal parenchyma, with some of the renal tubules infiltrating superficially into this nodule. The mass was formed by two components, as you can see on low power, a hypercellular stromal component that is set in a collagenous background formed by these spindle cells, as well as cystic dilatation that is lined by sometimes flat cells that look very bland. There's no atypia whatsoever in these flat cells. In other areas, these cells that are lining, epithelial cells that are lining these cysts show cuboidal arrangement with possible hints at cilia as well. And in other areas, they were also hobnailing. But whatever we looked at these epithelial cells, we did not see any atypia, any cytologic atypia. We didn't see any nucleopleomorphism or mitosis or necrosis associated with them. Surrounding these cysts, we see a sort of hypercellular, more hypercellular stromal layer that is forming around these cysts, cambium-like layer is what we call it. And away from these cysts, like we had discussed, these spindle cells form short fascicles, have plenty of abundant pink cytoplasm, sometimes with clearing, and are set in this collagenous background. Another thing that is notable for this tumor, particularly in the cellular stromal areas, is the intimate association with these blood vessels where the spindle cells look like they're spinning off of the blood vessels. This is a nice example over here that we highlighted. So when we think about renal tumors with cystic components, immediately this differential diagnosis comes to our mind. We think about cystic neoplasms with clear cytoplasm, tubulocystic renal cell carcinoma, and any renal cell carcinoma really can have extensive cystic change. But the two that would have both an epithelial component as well as a stromal component are the family of tumors we refer to as mixed epithelial and stromal tumors, as well as angiomyolipoma with epithelial cysts. And so to tackle this differential diagnosis in our case, we performed immunohistochemical stains. The epithelial cells were positive for both PAX8 in a nuclear fashion, as well as cytokeratin. The stroma was positive for estrogen receptor and CD10 focally, more enhanced in the cambium-like layer. We also thought that the stroma looked a little bit myoid, so we performed Desmond stain, which was positive. And all of these stains would be positive actually in both of our differential diagnoses, both MEST and angiomyolipoma with epithelial cysts would have all of these stains positive. So how do we distinguish MEST from angiomyolipoma with epithelial cysts? We performed HMB45, which showed rather striking positivity in the stromal component and not in the epithelial component. And then we also performed MELAN-A, which was a little bit more timid, but still showed up and stained a few rare spindle cells. So we were confident that this represents a case of angiomyolipoma with epithelial cysts. We also refer to this as AMLEC. It's a very rare variant of angiomyolipoma that is composed of these dilated epithelial cysts that are intermixed with usually a predominantly spindle cell angiomyolipoma. Both of these tumors tend to be benign, MEST or angiomyolipoma with epithelial cysts or AMLEC. So why is it important to distinguish them from each other? And the importance lies in the association of AMLEC with tuberous sclerosis complex. When you see an angiomyolipoma with epithelial cysts, the patient needs to be clinical correlation needs to happen to make sure that the patient does not have tuberous sclerosis complex, but because that will affect the patient as well as his family or her family. The origin of the epithelial cells that form these cysts is still debated. Some people think that they represent entrapped renal tubules that then become cystically dilated. In some cases, we see Müllerian differentiation in the form of columnar ciliated cells that are very reminiscent of fallopian tube histology. And so the possibility that these lesions could arise due to a very early embryologic abnormality in the urogenital ridge is still also a possibility. So we don't really know, the origin. We can't really know for sure the origin of these cells, but we think that they are benign. The Müllerian differentiation can also be seen in our differential diagnosis case, which is the mixed epithelial stromal tumor family of tumors. This family of tumors encompasses also what previously we used to call cystic nephroma. Cystic nephroma is the end of the spectrum in these lesions that have predominant cystic component. Once you have stromal growth or solid components like this case, then it becomes a mixed epithelial and stromal tumor. And under the new WHO, cystic nephroma is discussed under MAST. Those molecularly are thought to cluster together. So they are thought to be sort of two ends of the spectrum of a single lesion. Mixed epithelial and stromal tumors, like the name implies, have cystic epithelial component as well as solid components that correspond with the solid areas of stromal growth. And the cysts of MEST can be variable in size and shape. The epithelium of the mixed epithelial and stromal tumors can be flat, can be cuboidal, can be also hobnailing, similar to AMLEC. In some areas, we have seen also epithelial proliferation that shows pseudostratified columnar cells with tufting, sometimes with clearing of the cells. But the most characteristic finding in the family tumor of MEST is the ovarian type stroma that surrounds these cysts and that composes the fibrous septa as well as the solid nodules. Sometimes you can have variations on the stroma in MEST, and those can look a little bit more myeloid, like this particular case over here, where you have a little bit more sort of pink cells that are showing a sort of a myeloid look to the stroma. But if you look at the vessels, they look like they are bystanders rather than part of the lesion, like in AMLEC. And so we don't see these spindle cells spinning off of these vessels. MEST and cystic nephroma are considered to be benign multicystic tumors, very, very rare cases of sarcomatous malignant growth within the stromal component of MEST has been described. So very rare incidences of malignant transformation in the stromal component. But they are benign for the most part, and the clinical history is that of a female patient. Usually they're more common in females. They can occur in males, but usually the males have history of hormone therapy or hormone imbalance. And my last point on cystic nephromas is to distinguish adult cystic nephromas from pediatric cystic nephromas that are a different family of tumors and tend to have the DICER1 mutation, which the MEST family does not have. And so there's a distinction between adult cystic nephroma and pediatric cystic nephroma. So moving on in our differential of, or in our category of neoplasms with cystic components, we get to the cystic neoplasms with clear cells, and that encompasses really three main categories: clear cell papillary renal cell tumor, which previously was referred to as clear cell papillary renal cell carcinoma, and now has been downgraded to a tumor because of its indolent prognosis. It also encompasses multilocular cystic renal neoplasms of low malignant potential. Previously, a few years back, used to be called multicystic renal cell carcinoma, also downgraded to a neoplasm of low malignant potential due to its indolent behavior. And then, of course, in this differential diagnosis, we include clear cell renal cell carcinoma with extensive cystic change. So when you have a predominantly cystic mass that is lined by whose septi is lined by clear cells, and you have clear cell nests that are present within the fibrous septi, as long as they are not expanding the septi and or forming solid nodules, we can refer to them as multilocular cystic renal cell neoplasms of low malignant potential. Those are very rare tumors. Immunohistochemically and molecularly, they are very similar to clear cell renal cell carcinoma. But the diagnostic feature is that we should not have any expansile or solid mass, expansile nodules within the fibrous septi or solid masses. So clearly we need to distinguish them from clear cell renal cell carcinoma with cystic change. And the first part of this endeavor would really start at the gross bench, where we would look for nodules that are solid, or septa that are expanded and have a sort of orangish, yellowish hue. And if these sampling corresponds to the presence of solid nests of clear cells within these fibrous septa that are expanding the septa or forming solid masses, then this would make the diagnosis of clear cell renal cell carcinoma with extensive cystic change easy for us. In this differential diagnosis, sometimes what we see is fibrotic areas that are gelatinous and hyalinized, and microscopically they show hyalinization with sometimes rare single clear cells or sometimes without. And so the jury is still out on how to classify lesions that are entirely cystic but have these hyalinized areas. Some believe that these could represent tumor regression in the setting of a clear cell renal cell carcinoma. And some believe that, despite the presence of these fibrous hyalinized areas, you can still call it a multilocular cystic renal neoplasm of low malignant potential. I tend to be a little bit more on the conservative side. When I do see these lesions, I call them extensively cystic clear cell renal cell carcinoma with hyalinization suggestive of tumor regression foci. So I tend to be a little bit on the defensive side if you want. But the jury is still out and there's no consensus. Of course, within the differential diagnosis, we have clear cell papillary renal cell tumor. Previously, we used to call it clear cell papillary renal cell carcinoma. Now it got downgraded. This family of tumors, they can be solid, they can be cystic. Some of them are extensively cystic. But even in the extensively cystic tumors, you can still see some foci that perhaps have nodules of clear cells like this one. Even though they're expanding the septa, it doesn't matter. And then areas of the papillary growth pattern here, which on higher power would show the classical appearance of what we see in clear cell papillary renal cell tumors, which are the piano key morphology, characterized by nuclear polarity reversal, where the nuclei are more towards the lumen, and picket fencing next to each other, leaving the cytoplasm, which is clear under them, looking like piano keys. And this morphology is seen also in the tubular portion of this tumor, as well as potentially in these nests of clear cells. They can have papillary growth, they can have cystic growth, solid nested clear growths. And, features that are characteristic of clear cell papillary renal cell tumor can also be seen very focally in clear cell renal cell carcinoma. So if you see something that looks like clear cell renal cell carcinoma with very focal areas of clear cell papillary-like morphology, the likelihood of these being a clear cell papillary is unlikely. But if you really wanted to work it up with immunohistochemical stains, you can perform CK7, which is diffusely positive in clear cell papillary renal cell tumor. They both would be positive for CA9, but CA9 is box-like in clear cell renal cell carcinoma and is cup-like in clear cell papillary renal cell tumor, where the portion of the cytoplasmic membrane that is facing the lumen does not stain for CA9, and so it forms these cup-like pattern. Another stain that I find really helpful in this differential diagnosis is high molecular weight cytokeratin, which tends to be positive in these tumors. So clear cell papillary renal cell tumor represents about 3% of all renal tumors, and it is a low-grade indolent tumor. And lastly, in the neoplasms with cystic morphology is tubulocystic carcinoma that has a gross sponge-like appearance with variable amounts of variably sized cysts. And this corresponds to a really nice histologic correlation where you have variably sized tubules and cysts that are set in a background of hyalinized collagenous background or fibrotic background, sometimes desmoplastic. But in this particular tumor, you'll see that the cytologic atypia is not subtle, and most of these cells will have prominent nucleoli, and that's how we get to the diagnosis of tubulocystic carcinoma. In tubulocystic, whenever I'm considering the diagnosis of tubulocystic carcinoma, I usually perform stains because these usually have an indolent behavior. So I perform CK7, but mostly I really perform fumarate hydratase immunohistochemical stain to separate them from fumarate hydratase deficient renal cell carcinoma. This is a really nice example of FH deficient renal cell carcinoma looking resembling tubulocystic carcinoma set in this fibrotic background on needle core biopsy of the kidney. And so you really have to think about this and think about separating and this differential diagnosis by performing the stain, because you could have tubulocystic-like areas in a fumarate hydratase deficient renal cell carcinoma. Tubulocystic carcinoma also has been described to occur in the setting of end-stage renal disease. And whenever you have end-stage renal disease with acquired cystic disease of the kidney, you also have to separate acquired cystic disease of the kidney, associated renal cell carcinoma, and its precursor back-to-back cystic lesions from tubulocystic carcinoma. And the way to do it is look for these, your trusty friend, the calcium oxalate crystals that are associated with the ACDK lesions. And then, sometimes, like, for example, this is an ACDK associated RCC with focal areas that look like tubulocystic carcinoma. And so also look for the intracytoplasmic vacuoles that are more associated with ACD-associated RCC. So with this, we'll summarize. So we really went on a brief sort of summary of neoplasms of the kidney with cystic components, starting with our index case of the angiomyolipoma with epithelial cysts, how to separate it from its main differential diagnosis or mixed epithelial stromal tumors. And then we spoke about cystic neoplasms that have clear cells and how to separate them from each other. And then we also spoke about tubulocystic renal cell carcinoma. But the topic of cystic lesions cystic lesions of the kidney does not really end here. There's a lot more to talk about. We can talk about atypical cysts, especially associated with end-stage renal disease, and atypical cysts in the setting of syndromes and associated with syndromes. But unfortunately, for the sake of time, we couldn't get into those. I hope you really liked my presentation, and if you would like to take a closer look at the index case that I showed, the angiomyolipoma with epithelial cyst, I will be posting it on the GUPS high yield case section very shortly after our presentation, and so that way you can visit it and take a closer look at it. And with that, I'm happy to take any questions.
Thank you very much, Lara, for this wonderful presentation. Again, a complex subject. You made it look simple. So I think we have one question from Ali Amin. What is your criteria for expansile growth of neoplastic cells in cystic RCC? Any specific size for the nodule? And I think this is perhaps a burning question to a lot of us.
Absolutely, absolutely. I think it's a great question. What I don't know of any definitive criteria that are out there, but what I do is I usually look at the remaining portion of the neoplasm, and if I see this fibrous septa away from the nests of clear cells are similar in caliber, then this is likely to be not expansile. But if I do see the clear cell nests sort of filling up the entire fibrous septa and expanding it, then I tend to get a little bit more worried. I do correlate a lot, my gross impression with my microscopic, findings. And so usually when I go into the case, I'm usually already either looking for the expansile nodules or, confirming that I didn't see them on the gross. And so it's a great question. And I think, I think we do our best with it.
Yeah, thank you. So I think just one more quick question also on the same. How do you handle when you already mentioned about this potential tumor regression type of changes? I mean, if you apply that feature, in my experience, pretty much now it is impossible to make a diagnosis of this cystic renal tumor of low malignant potential.
Yeah.
How do you handle that?
Yeah, absolutely. Yeah, I totally agree. I tend to be a little bit more on the defensive side, especially when the hyalinized area is like the gross picture that I showed, extensive and sort of central and focal to the tumor. I tend to be on the safe side. I call them, suggestive of tumor regression and call them clear cell renal cell carcinoma with extensive cystic change. I have a great relationship with the urology department. And so I would tell them, not to worry about this. This likely will behave, in a benign fashion. So not to sort of worry about this patient and this tumor. I will also admit that if this is sort of an end-stage renal disease patient and I see focal areas of hyalinization and I don't want to jinx the patient's chances of getting a transplant, sometimes I turn a blind eye to these areas. So I think I handle them on a case-by-case basis, but most of the time when they're as extensive as this particular case, I tend to call them clear cell with extensive cystic, with extensive hyalinization, suggestive of tumor regression. I think this is still a contested area, and so would love to see future studies that could help us determine what to do with these.
Okay, thank you very much.
Sure.
I think that concludes our session. It is 12:15. I would like to thank every speaker for their wonderful presentation and all of the participants for active participation and questions. I would still again encourage participants to check out this PathPresenter GUPS partnership platform. It is a unique resource, and I think we really hope that you will find it helpful. Thank you very much.
Thank you.
Thank you all.
If the speakers could please stay on for a minute. As people are leaving, if everybody could look at their screen, their camera straight on, smile, and take a group picture as usual. Looks great. Thank you, everyone.
Thank you, everyone.
Thank you both for inviting us and for
Yeah.
for prompting us to do this. I hope you enjoyed the case, Samson. That was
I think it went very well.
he was
Okay, for the purposes of recording, I'm actually going to end the thing now, and
okay.
I'll catch you all in cyberspace soon.
Thank
Sounds
you.
good.
You all
Bye-bye.
have a great day.
Bye.